I feel a little bit like Potter Stewart when he was talking about pornography. He would know it when he saw it. I know compassion when I feel it. But how do we describe it? How do we get our arms around it? How do we think about it as a goal that's so central to the kind of health care and healthcare system that we all yearn for? And why is it so elusive? I believe you cannot have a compassionate healthcare experience or a healthcare institution or a healthcare system if you do not have compassionate people. So I think you have to start. If we're thinking about the elements that we need to have compassionate care, you have to start with compassion in the caregivers and even in the patients. Do we teach compassion if we don't select for compassion? Can you teach compassion? Can you learn even from the experiences of others? I would suggest that our best hope is that we can both elicit and teach compassion. Because I believe if we do not do a better job of identifying and eliciting compassion, that we have no hope of ever designing a health system that's going to act in a compassionate way. But what Beth asked me to reflect with you on is more than just how do we assure that we have compassionate caregivers, but what does it mean to have a compassionate caregiving setting, institution, or system? It certainly cannot be accomplished, I would submit, without compassionate caregivers. So the setting itself, in my mind, is at best permissive of the things that compassionate caregivers know to do and want to do. But how can the setting either facilitate or inhibit the experience of compassionate care? The first, in my mind, is time. You have to have time to experience the reality of compassion. You cannot always be running to the next. The experienced clinician knows how 5 minutes can feel like 3 seconds or an hour, depending on how you connect and what you do with the patient. But time is critical. Making most of the time is obviously important, but a setting that does not permit the time is not going to enable compassion. Secondly, you need the physical environment for the kind of interactions and intimate connection that every compassionate example exudes. You have to have the quiet. You have to have the degree of privacy. You have to have the environment freed of unnecessary distraction in order for the feelings of empathy and sympathy and compassion to be able to express themselves. Third, we need an environment which is not deprofessionalized and disrespected. The greatest inhibitor to individual caregivers showing compassion is that they themselves are disrespected, under stress, and not permitted to express their full professional engagement and responsibility. There has to be opportunity for the caregivers to have an escape, to have their own humanity reaffirmed. We need an environment which can counter the distancing of technology, because compassion is an intensely human connection. Before the stethoscope, the clinician literally had to lay the head on the chest of the patient, and the stethoscope permitted a distancing. Now, you can fast forward to robotic surgery at a distance, and you can imagine how the advent of technology, which offers so much possibility, comes ineluctably with the distancing. And so we need to be able to overcome that distancing. As long as we have a system which puts financial pressures on the deliverers that requires them to think first and foremost about the financial transactional character of the relationship, that it's an inhibitor to effective care, to compassion. And so it's not about only how the funding flows, because healthcare depends on funding, but how is the clinical experience arranged so that the reality of the economic surround does not intrude constantly on the experience of the patient and the clinician. And so if we think about those healthcare designs which allow the space and the environment, the time, the respective professions, the absence of depersonalization, the overcoming of the distance introduced by technology, and insulation from the extraneous pressures of the financial reality of healthcare, then I would submit you have the possibility of an environment in which compassionate caregivers and patients have an opportunity to experience compassionate care. And the final element that an organization can introduce are the rules and procedures that reinforce the best of compassionate experience. So you can have requirements and expectations of talking to the patient and eliciting the patient's wishes. You can have rules about silence and lack of side conversations when you're in the presence of the patient on rounds. You can have procedures and policies that protect the professionalism and the integrity of every health caregiver so that they can be fully a part of the patient experience and the professional experience. You can have the rules in place about systematic guidance, the kind of checklists, the kind of routines that protect safety and that therefore enable compassionate care to be expressed. In the end, a healthcare institution and a health system that gives compassionate care is a health system that is giving safe and high quality care. It's a health system that's giving good value for the amount of resources that are expended in care.